So when we talk about hepatitis B vaccination, we have two populations to consider. First, those that are immunocompetent. The vaccines that we have and have had since the 80s are excellent in that population in terms of preventing infection, with the caveat that we do not do a very good job, as revealed by a recent large study, that in fact patients receive all three shots that are required to achieve protective responses. In the immunocompromised patients, including those with HIV, we face a different story. In those patients, the current standard vaccination routines are not nearly as effective. In those with HIV, standard vaccination procedures give us a protective response in 35 to 70% of patients, leaving us with a big gap. In recent years, there's been efforts to find ways to bridge that gap, and those include more frequent dosing, increased dose of the actual vaccination protein, alteration of the site where the vaccine is given. In other words, perhaps intradermal versus subcutaneous versus intramuscular vaccination, and most recently the addition of adjuvants that may help improve the immune response. All show some benefit in some patients, but we have yet to achieve the nearly 100% vaccine response that we see in immunocompetent patients. Well, for many years, when we only had pegylated interferon, the majority of patients with HCV/HIV co-infection were not actually treated. Patients and their healthcare providers shied away from offering and providing those treatments for Hep C because of the high rate of side effects. In the era of DAAs, which came to fruition with all DAA regimens in 2013, we're seeing similar rates of response rather than decrements in response, and greater patient and physician acceptability of those regimens. So the modern era of DAAs has really changed the world in the co-infected patient, and for the first time lets us think about eradication of Hep C in HIV, which would eliminate one of the important causes of chronic liver disease.